We're going to talk about prevention of nausea and vomiting after breast cancer surgery. This presentation is for the Breast Cancer Resource Center of Santa Barbara, and my name is Laurel Schooler. I'm a board-certified nurse anesthesiologist with about 13 years of practice, and I've administered approximately 10,000 anesthetics to patients. I did my doctoral research on breast cancer patients and best case scenarios for prevention of nausea and vomiting in surgery. And I've also personally experienced nausea and vomiting after surgery and know how debilitating it can be. And I'm a patient advocate for these patients that have the nausea and vomiting. I'm also a clinical professor at the USC in Los Angeles, and I work with the Sierra Pacific Regional Anesthesia Consortium. And I've incorporated a lot of my research findings into my own practice and have seen a dramatic increase in patient satisfaction and a dramatic decrease in nausea and vomiting. So women predominantly are the most vulnerable patient population to experience nausea and vomiting, with the incidence as high as 80%. Other contributing factors including non-smoking, an age of over 50 years old, and the perioperative use of narcotics, and the type of surgery, which is breast and gynecological surgery. Problems with nausea and vomiting in the perioperative period include simply patient discomfort, prolonged hospital stays, and admission from outpatient surgery to the hospital, wound dehiscence, which is wound breakdown, electrolyte imbalance, increase in costs, staffing, prolonged bed occupancy, aspiration, pneumothorax, and esophageal rupture. How do we prevent postoperative nausea and vomiting? Well, the first thing to do is to determine which patients are the highest risk. Primarily we use the Apfel nausea and vomiting risk factor scoring system. And as you can see, female patients get 1 point, non-smokers, a history of postoperative nausea and vomiting, and the use of opioids, and age less than 50. And most breast cancer patients have an overall risk of 3 to 5. So the consensus for treatment modalities is any adult that has these risk factors to use a combination therapy of at least 2 antiemetics from different classes. But even with these recommendations, there's really not enough data to recommend one specific therapy combination over another. So once you've determined that a patient is high risk for nausea and vomiting, if they just have 1 point on Dancitron or Zofran is really the first line of defense. 2 points would be on Dancitron and Decadron. Decadron is usually administered early on in the surgery, and the ondansetron roughly about 30 to 60 minutes towards the end of the surgery. Someone who has 3 points, which are most of our breast cancer patients, should be receiving ondansetron, Decadron, and maybe a long-acting nausea and vomiting prevention, such as Operative, which can be given the morning of surgery with a sip of water, or scopolamine patch. These are the only 2 antiemetics that will provide nausea protection for 72 hours after surgery. Patients with 4 or 5 points, which are extremely high risk, we would use 4 different classes of antiemetics and consider a total IV anesthesia. Additional considerations, we talked about the 72-hour prevention with the Operative or scopolamine patch. Total IV anesthesia. You can also give acetaminophen with a sip of water the morning of surgery. Ranitidine, famotidine, gabapentin with caution because patients can become sleepy. Celebrex if applicable, or opioid-free anesthesia, and additionally the use of regional anesthesia. Patients can request to have a epidural or a pectoralis 1 or 2 block. Using the enhanced recovery after surgery protocol has also helped with to prevent dehydration and faster recovery and less incidence of nausea and vomiting. Other considerations could be ginger root, alcohol swabs, a TENS unit, or a wristband. And this is a picture of the pectoralis nerve block with the dermatones. You can ask your physician or nurse anesthesiologist to perform this. It's done under ultrasound, either preoperatively or some providers will do it while you're asleep. And this will provide anesthesia and pain control for several hours, sometimes up to 24 hours after the surgery, which requires less opioids. And this is another picture of the PEX 1 and PEX 2 block. In summary, breast cancer patients are among the most vulnerable populations to experience postoperative nausea and vomiting, with a 6-fold risk than the overall general population. So what we've discovered is that a standard protocol with an approach to postoperative nausea and vomiting resulted in a less than 10% incidence, which is really an attainable goal. No antiemetic is universally effective in preventing and treating postoperative nausea and vomiting. However, each additional adjunct antiemetic has shown to decrease the incidence of approximately 25%. Again, my name is Laurel Schooler at Santa Barbara Plastic Surgery Center, and I'd like to thank the Breast Cancer Resource Center of Santa Barbara for having me. And happy Pink Week!